Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and I am back in our sunflower house, and we are going to continue a most interesting podcast with a wonderful guest. I'm so thrilled to have Dr. Elena Christofides back on our podcast to finish our discussion on everything women's health, anti-aging, and hormones. I gave her very impressive background on our first podcast, so I won't repeat all of that other than to let our listeners know that she's the founder of Endocrinology Associates in Columbus, Ohio, and she's a leading medical researcher and physician on metabolism, diabetes, and related processes. So if you haven't had a chance to listen to our first podcast interview, I definitely recommend that you go back to listen to that, because we talked about how hormonal health significantly impacts women's well-being as they age. And we covered some of the common health challenges that women face, some potential treatments, and especially the importance of a personalized assessment to optimize health through lifestyle as well as pharmacologic measures. So we are going to jump right in and continue that conversation. Welcome, Dr. Christofides.
Thank you. Thank you so much for having me back on, Dr. Thacker. This is such an honor.
Oh, it is so great to have you, and you do such great care of patients. And I'm so interested in your innovative practices and what you do to help patients make the most of their life and their lifespan. Tell me, what are some of the common blood tests, or are there any special blood panels that you recommend for your patients?
Yeah, we have actually a whole new patient panel that's kind of automated in our system because most patients tend to come with similar complaints and then a few extras, obviously, along the way. But we do have a set panel. And so a lot of it is stuff that you would think is obvious, like a complete blood count, a chemistry panel, liver panel, etc. But what's often misunderstood about doing these things all at once is the relationships between different levels of your complete panels or your blood count actually gives me a lot of insight around, what's the state of balance of your system? Because yes, there's the normal ranges, but you and I both know those don't really apply in endocrinology. So I'm interested in how things relate to each other. And then things that I specifically do that I've never seen anybody else do are things like the MTHFR the enzyme pathway, which looks at your B vitamin metabolism. I do that genetic pathway. I do a lot of hemochromatosis genetic analyses as well, because, that's
similar. We're so similar. We're like two sisters from another mother.
I feel like in the Midwest, especially, we have such a large, Northern European, British Isles population, and that's quite a common disease of that population. And I feel like doctors have stopped talking about it. And so you have generations of individuals who have no idea that this is happening and contributing, right, to their liver disease and their metabolic health. And then obviously the vitamin D. I mean, I think we talked about this even on the last one. Like you got to get a vitamin D. You got to know where people are. But the other things that I do actually relate to the lipid profile. I think people are getting more aware of like ApoB levels and little, LP little a levels, which help me really understand, where someone's lipids are and where they need to be, whether we're going to treat or not treat. I mean, the point is kind of need to know what you're looking at. But I also, especially if someone has a concern for lipids, I also do an ApoE genetic screen. So
you
I don't
think that's opening a can of worms, do you?
Well, but they're there to open a can of worms. Otherwise, they wouldn't be seeing me.
I guess you're right. I mean, I'm just curious. Did you have your ApoE genotype done?
Yes, actually, my entire office staff has done it. I've done it. I've had my entire family, because we do have dementia that runs in our family. It runs in several, family members of various employees, and a lot of patients are very concerned about dementia.
Oh, very much so.
Very,
yes.
Very concerned. And I think that it is an underappreciated relationship. I mean,
Yes.
Because I want to be able to tell them, okay, this is where you are right now. This is where your genetics suggest you might be going. And then let's look at your family history and assess what your risk is of treating and not treating, or what do we treat with? Because that's also obviously part of the conversation. So, I'm already doing the MTHFR and the hemochromatosis genetic screening. I don't feel like adding the ApoE is any more risky because, that's still a prevention that people are interested in. And do we have good answers yet? No, but we certainly have. It's better to know and know what you're working against versus like wondering.
Now, I previously got a lot of MTHFR mutations, and I know one of our lead geneticists, who was a top scientist, unfortunately recently passed, Dr. Karis Ang, MD, PhD, opinion was it's such a common mutation with half the population having one defective gene that it really shouldn't be done. And I still did it because I have a hard time having people do what I say. And for the people that are homozygous with two mutations, they're going to oxidize their brain faster. And so for me to get them on the methylated vitamins, but then I started to have pushback, and insurance companies would charge people like $700 or $800. And so now I'm just kind of erring on anyone who's interested in brain health, anyone who might have an increased risk of blood clot or prior DVTs or miscarriages. I'm just saying you need to be on methylated vitamins. And in one of my podcasts on brain aging, where I went over some of the research showing reductions in brain atrophy in those that are on N-acetylcysteine and the methylated vitamins and Serofolin NAC, now over the counter as Serofolin Brain Wellness, that I'm just so much more liberal at saying, let's just take this vitamin. So are you having insurance pushback? Or also, what about people long-term care if they have a family history of dementia and they're, ApoE44, is that going to make it harder for them maybe down the road to get disability or to get long-term healthcare insurance?
I mean, that's a lot of great points and great questions, obviously, that need to be taken into consideration as part of the discussion. So let's talk about the insurance and the pushback and the coverage. I have yet to have a lot of pushback on that, and I have not had patients getting charged that kind of money.
Wow, great.
Which is great, and maybe just I'm lucky. But I will say that enough psychiatrists are doing it through gene site testing that I'm getting the data either way.
Yes. That's wonderful.
Right. And in addition, you get it with any of the genetic tests like 23andMe, Ancestry, et cetera, that people are also doing. That's showing up on those as well. So
is that as reliable? Because I know that when we talk about cancer genes, we always tell people recreational genetic testing, sorry, they only test for a few genes. And even though 23andMe expanded it, which I think they've just undergone chapter 11 or something. So
reorg.
I don't know what's going to happen with all that data, that I still feel like when I'm really concerned about genetic problems, I want them to see a genetic counselor and get official medical genetic testing, which is getting cheaper every day.
Yeah. I mean, you're absolutely right. I will say I have yet to find a single inconsistency in the 23andMe genetic testing for the stuff I'm looking for, like hemochromatosis and MTHFR. Those are in there. The ApoE is in there. So with one $200 test, you get 3 genetic markers that don't enter into your medical record. So, I sort of feel like they have been accurate enough, and they are outside the medical field enough that for patients who are concerned about any sort of backlash, that's one way of doing it. And obviously with their chapter 11 reorg, that could be potentially messy. So I have that discussion. That's obviously a discussion for that individual patient. Some patients are concerned, some patients aren't concerned. And I haven't had it influence the issue. Yeah.
It's so interesting in terms of data. My son, who I've had on this podcast, in fact, one of my patients the other day just said, have him on again. I really enjoyed that. And I know I'm going to have a lot of people ask me to keep having you on regularly yourself. But he's a PhD in molecular genetics. And basically in terms of some of these discussions about, how much is genes, how much is an environment, in terms of just costs coming down and how is it going to influence everything. um, it's really can be a very thorny issue, and there's so many different aspects to it. We've had a genetic counselor come on and talk about the GINA law, and
Yeah,
I personally think that knowledge is power. And I
agreed.
always encourage my patients, when you have something done like gene site analysis that tells you how you metabolize psychiatric medicines, pain medicines, whether you have this MTHFR mutation, which is how you metabolize B complex vitamins that affects a lot of brain chemistries, that you need to keep records of it. But the
Yes.
one discussion I've had with my son, like, he did ancestry and my other son did 23andMe, and people find out you're related to other people you didn't even know, and find out you have other family members that you didn't know really wasn't your grandfather. It's crazy. But
Yeah.
I just personally didn't like my genetic information out there. And he laughs at me and he said, anybody can get your genetic information, mom. You
Yes.
suck on a straw
Yes.
and there it is. And that's why when
Yes.
you say it's outside the medical record so people can't get it, I mean, I just had
Well, it's
my,
outside of the well, it's outside the official medical record. So I don't
yes.
disagree. I don't disagree with your son. I think that I understand the concerns, but it's not like people are out there cloning humans yet. I think we've got a ways to go. You're right. You sip on a straw, you use a cup. If somebody wanted your genetic material, they could get it. When I say outside the medical record, I mean outside the official medical record, because those are not part of the official medical record. Those are not in your medical chart unless you choose them to be. And realistically, the pre-existing condition clauses were part of the ACA. You can't, I mean, the ACA Act did forbid, discrimination against prior knowledge and pre-existing conditions. And honestly, I haven't seen, so let's also put it this way. If people were doing perfectly great and healthy, they wouldn't be in my office. So I think that there's a role for this genetic testing. Again, if you're doing great, congratulations. I'm happy for you. Like, that's
Yeah.
fine. Like,
Those people don't come see you and
those
me.
people are
I
not the ones who are
understand.
coming to see me.
Yeah.
So if you're trying to optimize what you're doing and trying to optimize your health for longevity, then these are things that are important to your longevity story.
Mm-hmm.
But at the same time, when you're filling out these forms and you're filling out all this documentation, they don't believe it anyway. So you're right. The medical profession tends to push back on these as being irrelevant. So on the one hand, we're sort of protected right now due to the ignorance of the profession, believing that these genetic tests are not really valid or important. And I'm happy for them to continue to think that 23andMe is terrible and not valid. It's great. That's fine. Let them do that, because that means that all this testing that people are doing for their health and for their longevity isn't going to be viewed as being viable. So that's fine. We'll get the data and then use it to what we need it to be used for, and then let it not be part of the medical record.
I guess I'm just such a privacy hound, and I recently had my bank account hacked, and money was being transferred, and one of my banker sons was like, "Well, Mom, all your passwords, all your data, it's everywhere." And
Yes.
so
Yes.
I do think that people should at least respect their own personal data and keep records, because it shocks me. Years ago when
Yes.
I was in practice, people came all organized, with their files. And now everyone says, oh, just go look online. And all these computer systems don't always talk to each other. But
No,
anyway,
true.
I want to talk about part of your specialty in your practice is growth hormone testing and screening. And I know that's very controversial. So tell us what is growth hormone, and what role you see.
Yeah, it's absolutely right that it becomes controversial. I think fairly so. So growth hormone, I think everyone understands when you're young, when you're a child, you need it to fully realize your adult height. And in proportion with puberty, this reaches your adult height. This helps you grow tall, so it makes your limbs grow longer, right? And then once you're an adult, you need it to maintain metabolic health and sort of fill the spaces in between. So it doesn't, do you remember that old commercial back in the 80s with BASF? They were a chemical company and they said, we don't make X, we just make it better. And they used to advertise on like cassette tapes and all kinds of manufactured goods. And I'm clearly
You're
dating
dating
myself.
yourself, doctor,
Yes,
and you
I'm
look so
clearly,
young.
clearly dating myself. But I always loved that commercial because growth hormone, it doesn't make you lose weight, but it makes you fitter. It doesn't make you heart healthier, but it makes your heart happier and mental health, etc. It does many, many things. So it maintains stability of mood. It maintains metabolic health and, improves insulin sensitivity. It improves muscle function and muscle strength and muscle conditioning. It improves healing. It improves recovery, especially of the soft tissues. And it is a critical hormone as we age to stave off the aging process. Now, unfortunately, yes, too much of a good thing is bad. Growth hormone has to be regulated, and it has a very clear sort of zone of no-go in terms of when you're treating and when you're replacing and when you're managing it, where you don't want to be, because it does have consequences when it's too high. But what's interesting about growth hormone is that 1 in 5 head traumas can produce adult onset growth hormone deficiency. So whiplash, car accidents, sports injuries, concussions, and repeated head injuries. And let's not ignore the fact that many people might be in a physically abusive relationship and they may not disclose.
We had a podcast on domestic violence, intimate partner violence.
Yeah.
That's a good point. I didn't even think to put those two together.
Well, I mean, this is a question that I ask when I'm looking. So I also, you were asking me, part of my routine screening labs is I routinely screen IGF-1 as well. So an IGF-1 is a screening tool. It's not a diagnostic tool, but it's a screening tool that gives us an idea of directionality of your growth hormone. And if it looks out of balance with where I really want it to be, then I might suggest a growth hormone stim test, but I'm going to do a history. And when I take the history, I'm asking specifically about head trauma, and I'm asking about, partner violence. I'm asking about domestic abuse. And obviously, I try to make it a very safe space for people to talk about it. And I'm always surprised at how much domestic abuse occurs, whether it's from childhood and it's just cumulative over the years. And it may not be happening to an adult today, but it may have happened in their life. And I've had people tell me, that they were thrown out of windows as children and repeatedly abused and, thrown out of moving vehicles. And these are things that can cause lifelong trauma to the poor little pituitary gland. So growth hormone, it's the reason it's so controversial is because it's such a hormone of abuse. If it didn't work, the athletes wouldn't all be using it. So my philosophy is, though, but anything is a hormone of abuse if you let it be. Everything can be abused in the wrong hands and in the wrong understanding. And when people push back on that, the next thing I push back in is I say, well, bodybuilders and athletes also take insulin as a growth hormone, because insulin is also a growth hormone. I said, so they also, right? So they also take insulin in their recovery and in their, bodybuilding world. I said, so are we going to ban insulin now because somebody's abusing it? So the absurdity of the argument that we shouldn't look at it because it's a drug of abuse is always, irked me. Because if you have growth hormone deficiency, you age faster, you have a shorter life expectancy, you are more insulin resistant, you have more metabolic ill health, you are higher on your lipid values, you are higher blood pressure, you're more likely to be developing premature coronary disease, more likely to have poor recovery, and so you're going to last at the gym longer, you're not going to be as fit. So there are significant reasons why someone might want to replace their growth hormone if it's deficient, if they're interested in maintaining, well health into their older years. It's not going to turn you into an elite athlete. And here's the other part that kills me on this one. You could give me all the elite athlete drugs in the world you want. It's not going to turn me into an elite athlete. I just don't have the genetics for it. I don't have the physique for it.
Me either.
So, right? Like I used to joke all the time about that these are things that enhance what you have in genetically, what you're doing physically. But if you are someone, and one of my favorite, stories is I have a patient who was a triathlete, and he was noticing significant drop-offs of his time and his performance. And we went through, and I'll be damned if he didn't have hemochromatosis and MTHFR and growth hormone deficiency, all three. So of course, by the time he was the age that he was when he came to me, these three conditions had cumulatively led to a significant drop off of his performance. Not that any one did it, right? It's not any one thing that did it. It's the fact that he had a series of things that were cumulatively leading to like declining performance. So we fixed all these things, fixed his nutrition, got him a CGM. We're tracking his nutrition, tracking his glucoses, teaching him about nutrition, which I know we're going to talk about later.
CGM is continuous glucose monitoring for our
Yes,
listeners.
exactly. Thank you. Yes. And, his performance improved. He was able to use the data to improve his weight, improve his diet, improve his lifestyle. He used, the data to help him improve his fitness and his training performance. And, we just gave him enough to make him back into like his normal, what would be his normal range for his age. And obviously, I'm not one of those clinics that just gives people like these ridiculous doses and doesn't care about their levels. I track their levels. I track their blood count to make sure they're not making them polycythemic. I track their vitamin levels to make sure they're not being toxic. I mean, there are ways to do this safely and appropriately. And so now he's back to performing at the level that he wishes to be performing at.
That's an interesting story about hemochromatosis because, as many of my listeners know, I run the Center for Specialized Women's Health, and I was boarded in internal medicine, going to be a cardiologist, got extra training in endocrinology and gynecology and female hormones and osteoporosis and just kind of interdisciplinary women's health. But one of the things that helped put me on the map early on in my institution was there was this executive who had all these problems and went from, internist to cardiologist to gastroenterologist. No one could figure out what was wrong with him. So I get a call from the CEO saying, you got to figure out what's wrong with this guy.
Right.
I'm like, okay. Right. He had hemochromatosis.
Yeah.
And so that, got me immediate respect, so that when I went to the CEO to say, hey, I got to, build something that's different than what we have, that really can help women. I mean, I had an open door because of that diagnostic respect. So, and I think
so kudos to you for that. I mean, my son calls it like being Dr. House, but the nice version, not the mean version. And, that's what I always say too, because at the end of the day, these diseases of genetics and genetic inheritances, they take a while to show up.
Yes.
And unfortunately, that's also the time when, we start to get a little gaslit along with the providers in our 40s and our 50s of, well, that's just aging. Well, no, some people are aging faster than others.
Oh, definitely. Definitely. So, who are the people that you get the growth hormone screening on?
So every patient who comes through my door, it's part of the new patient panel. We do an IGF-1 on everybody.
Okay.
Because the vast majority of people coming in have complaints that are consistent with growth hormone deficiency as well, right? Fatigue, difficulty sleeping, gaining weight around the middle, their gym performance is dropping off. So it is part of my routine panel. And you'd be surprised at how many acromegaly patients we've also found screening that way. And acromegaly is a disease of excess growth hormone when it's produced by a tumor in the pituitary gland, and it leads to significant deformities, physical deformities, as well as, medical conditions.
And increased cancer rate.
Yes, exactly.
Yes, I have had a few in my practice.
So we have a bit of a reputation in the pituitary world that all of our acromegaly patients have what we call microadenomas, or small tumors that are curable when surgery, because we seem to find them so early, because we're not waiting until they're 20, 30 years on with these symptoms before somebody's checking this level and discovering that they have quite a large tumor that is no longer, perfectly curable with surgery. So, it's just part of our routine panel now, the IGF-1. And it's, if it's out of range. Now, here's the thing about out of range is that the range is quite large. So I will recommend a growth hormone testing protocol, which is a little bit more in depth than an IGF-1, for anybody that is below the mean. And this is an important distinction because men and women have different ranges of normal. Mm-hmm. And it's quite broad. It's quite broad in range. And we know epidemiologically in healthy populations that the IGF-1 should be about mean to about 1 standard deviation above the mean. It's about where the normal range really is. The range that's reported on the lab is the mean plus or minus 2 standard deviations, and that's the actual range. So if you look at the range, it's kind of misleading because it actually catches the hypo growth hormone patients or the low growth hormone patients. So I look for it to be mean to just, between the mean and the upper range. Mm-hmm. And if it's not there, then I recommend growth hormone stim testing.
Very interesting. You were talking about the metabolic syndrome, and you've been listening to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, the executive director of our nonprofit, Speaking of Women's Health. And I am speaking with endocrinology, metabolic expert, anti-aging expert, Dr. Elena Christofides, who has a practice in Columbus, Ohio. And you were mentioning this fatigue and weight gain, muffin belly around the belly, poor sleep. I mean, I hear this, of course, every day.
Right.
And I was remarking to my specialized women's health fellows, who do a 2-year additional fellowship with me after their initial board certification in their primary specialty, that when I started in this field, it was like easy and fun. Because there wasn't like the negative connotations about hormone
Right.
therapy, which we finally now gotten past that almost 23 years later post
Thank
Women's Health
God.
Initiative.
Thank God.
So that part's good. But what's also harder about it is like when I saw women initially, they had classic menopausal symptoms, hot flashes, night sweats, maybe poor sleep, dry vagina, plus minus bone loss. Now the women I'm seeing, they have all those symptoms, plus they have so much more. And they have metabolic syndrome. I mean, I rarely saw a patient with type 2 diabetes or a woman with central adiposity in my practice, which was a referral center when I started in this field. Now it's unusual for me to see a thin woman.
Yes.
So I've done podcasts on our food supply and all these substances that are poisoning us that are not allowed in other countries. But it just seems like the prevalence of metabolic syndrome is out of control. And I've, as part of my lipid profile and LP little a and inflammation markers, and I'm pretty frequent and lax to say, yeah, go ahead and get a coronary calcium score. Although I will say some women's health cardiologists say you can't exclude, soft fatty plaques. But since I try to keep women off of statins because they increase diabetes and they don't have any primary prevention, and
Right.
everybody wants to put statins in the water,
Yes, I
and
know.
I think that's pushed too much. I mean, cholesterol is needed for hormones and brain metabolism. And I think we've gotten
Agreed.
too far off on the statin issue. But I've been getting omega fat ratios. Are you including that in your panel? And hardly anyone I see is normal. The only normal people are either eating fish 4 times a week, not twice a week.
Yeah.
Um,
Yeah. Oh, no, absolutely. So we had previously a really excellent lab for doing the omega ratios, and I really, really loved the lab. And unfortunately, they are no longer in existence. So it has been difficult for us to find a lab that I can trust for their omegas. But you are absolutely correct. I mean, omega is a huge problem. When you talk about the food supply, omega is one of the biggest gaps in food supply health that we have compared to the rest of the world. And it is an interesting problem. I typically just recommend, this is a funny one. This is actually where I just usually recommend supplementation
really?
over even screening, because no one gets enough omega-3s in this country in their diet, regardless. And an interesting point, I'm going to actually bring something up because I know we're talking about a little bit about nutrition. A funny little story. Did you realize that grass-fed beef and bison have more omega-3 fatty acids per ounce than seafood?
No, I didn't know compared to seafood. And I thought like mackerel and tuna. I had mackerel for lunch. I'm going to have sea bass tonight for
Yeah,
dinner.
but for our patients, though, for our patients who are not interested in seafood or are
Yes,
concerned about their seafood supply, because that's also a real issue,
of
overfishing of
course.
our oceans. I mean, and that's the case, then I just ask them to make sure they're doing grass-fed beef and bison and wild game, which has plenty of omega-3s in it. And grass-fed beef in particular, and grass-fed milk, grass-fed butter, those products, grass-fed cheese, you've already got a higher concentration of the omega-3 fatty acids.
Yeah, I pretty much switched over to most grass-fed
Yes. Yes.
products. It's more expensive, that's for sure. You have to be, careful that that's what you're really getting.
Yeah, but you
But
can make up more of that difference though with, like, if you're doing the butter as well as the cheese and the milk, right, and the cream. So
mhm,
it's incremental benefit, right? It's
yes.
incremental. Yeah.
And I always recommend to my patients to get the omega-3 eggs. And of course, eggs were so high priced because they were killing all the hens, but now they're coming down a little bit. But if they feed the chickens flax, that's another non-seafood source. The only reason I bristle a little bit about saying just take a supplement is because weight is every woman's concern pretty much. And, all I had to do is eat a big apple, 300 calories for 6 months to gain, 25 pounds and have a baby in 6 months. And, there's extra calories in some of these supplements. And I just personally would rather be enjoying my calories than swallowing them.
Sure.
Because you have to keep restricting the calories you're eating the older you get.
Well, this may blow your mind. I never have my patients restrict calories.
Really?
Yeah. So the calorie cult is not a cult that I belong to.
Interesting.
Fat is your friend, not your enemy. Protein is critical, right?
I'm definitely in that. There's no essential carbohydrate is my little saying.
Exactly. So I would rather someone get their omega-3s, whether it's a supplement or a food. And I don't disagree. Obviously, I would rather you enjoy your food as well. But again, that becomes a cost issue. That can become a lifestyle issue. That can become allergy. A family. Yes. Yeah. And a family issue, right? Like if you can't, like if I'm cooking for my household where I have two 25-year-olds that are athletes, we can go through 2 5-pound briskets in one dinner. That gets expensive. And so I understand that. I understand that people are like, well, I'm feeding a large family. I can't buy a 10-pound, grass-fed brisket for my family. That gets really expensive. So I understand that. So I guess my point.
I've gone to giving grass-fed beef as like a birthday gift to my older son. It was unfortunately delivered to his next door neighbor, a Browns player who somehow thought his name was Stetson, even though there's no Stetsons on the Browns team. So I had to order another one.
Yeah. So it is always a funny thing in the summer when the boys are doing the triathlete trainings and they're doing their races, and one farmer's market, and I tend to get a lot of it from the farmer's market because I want to support our farmers. I want to support direct purchasing. I want to support local produce, and I can talk to the farmer and know what they're doing. And I know where they're raising their cattle, and I know how they're, doing it's sustainable, ethical farming, right? That's what I'm trying to rely on. And I'll never forget that one Sunday, I thought I was going to make extra and have some for the week. And I put these 2 briskets on the grill, and by God, I didn't barely get them off the grill before they were gone. And I thought, okay, well, this is maybe not the wisest strategy for when the boys are in training. So with that being said, I don't disagree with your point about the calories. I don't disagree with your point about the supplements. And I would rather, better eating, better living, better focus on our nutrition and making those calories count, making our food count. Because I too love mackerel and sardines. I mean, I have canned mackerel and canned sardines around all the time, and I'm constantly fighting with the cat when I have to open them. So I'm always taking them to my office and eating them in secret so the cat doesn't, try to steal my mackerel. But at the same time, I also appreciate that if you're dealing with somebody whose health has already been damaged, then we have to deploy every tool in our toolbox. And that's one that I'm willing to take the hit on. Yeah.
And what foods and vitamins legitimately support a good metabolism in particular?
Yeah, so I'm going to talk about them in terms of vitamins, and then we'll talk about the foods that support that or the things that support that. So omega-3s, we've already talked about, hugely important for reducing metabolic syndrome, improving glucose metabolism, improving vascular reactivity, which lowers blood pressure. It, of course, improves clotting risk. So it lowers clotting risk and decreases atherosclerotic reactivity. So hugely stabilizing. And we just talked about the food sources where you can get more omega-3s in addition to the supplement. I mean, you and I have talked about vitamin D, I think, till the sun goes down. I mean, vitamin D, vitamin D, vitamin D, vitamin D. Vitamin D is the first step in metabolism to every hormone in the body.
Yes.
Every hormone, including your lipid metabolism. True epidemiologic normals are 65 to 85, not what the lab says.
If I have another patient tell me that their primary care doctor told them to stop their vitamin D because it was 87, I want to pull my hair out.
I think I turn into the exorcist when this happens and my head starts twitching and I think I'm going to start spewing. I mean, it's so prevalent. It's disgusting. I don't disagree. And so I agree. Vitamin D, 65 to 85 is the epidemiologic range. What's the consequence of too much vitamin D? Nothing if it's the inactive form, because your body will regulate how much it needs to convert from the inactive to the active. And
Mhm.
so even drifting up to 100 is fine. This is cholecalciferol we're talking about, which is a white powder capsule, white powder that you purchase from special suppliers, like certain vitamin shops. Like I do not let my patients go to CVS, Target, Walgreens, Meijer, Costco, Walmart, because those are not high quality versions of vitamin D. Because vitamin D is so it is so sensitive to this process of manufacture
And do
that
you routinely add K2 to it if your patients aren't eating Japanese natto or
no,
food-rich
I don't
sources?
actually.
I I
I have
I
not
do,
found that. Yeah,
and
I know it's back and forth.
I've seen improvements in bone density, and since there's some epidemiologic research that shows more coronary calcifications with increased calcium or vitamin D intake, I figure I want the calcium in the bone, and M7 or K2 helps drive that. It has nothing
Yeah,
to do with blood clotting.
completely agree with you. I mean, if somebody wants to take it, I have no objections. I just don't proactively prescribe. You are absolutely right about the calcium increasing the risk of vascular disease and atherosclerotic disease. And I think my personal opinion is that correlative data is related to the fact that in the study, these people were all vitamin D deficient. And in the absence of vitamin D, you don't have the cofactor to take calcium into the bones.
Yes.
So, because you have to have the two together to go into the bones. Otherwise, the calcium is free floating and has nowhere to go.
Hmm.
So, with the vitamin D, there's only a few brands and they're available on my website in terms of links to Amazon as to the brands that I've seen that work
Hmm.
because so many brands don't work. And this is not a prescription. You cannot get a prescription vitamin D.
I know. I tell patients the non-prescription is actually better than the D2 prescription.
Yeah, because the D2 prescription is the active form. You can get toxic on it, and that's not what your body needs. In the world of
Yes.
endocrinology, what's really not understood sometimes is the world of endocrinology. Your body needs the inactive form of the hormone in order to be able to convert it to the active form in order to do the job of the hormone.
Sure.
So that's the same thing with T4 and T3. You would give T4 because your body's supposed to convert to T3. Now, obviously, we know some people don't convert well. We have to supplement, and that's fine.
What percent of your patients do you have on T3? Because I know a lot of our endocrinologists are resistant to using T3, and I think I have about 5% of my women patients on it.
Oh, no, it's probably closer to 50% for me.
For you, wow. Wow,
Well,
you probably
because
see tougher
there
cases.
was a big, well, actually, there was a big series of patient evaluation, big series done and presented at the ADA, American Diabetes Association meeting a few years ago that showed that there was a higher likelihood of T4 to T3 conversion disorders genetically in patients with more obesity.
Okay, yeah.
So if I have somebody
So
who's
if someone's
thyroid,
obese, that
mhm.
would be
Yeah,
mhm.
so if I have a thyroid patient who also happens to have obesity, or I have a thyroid patient who also has other autoimmune diseases, they tend to do better with a combination. Now, I obviously prescribe them separate. So with that being said, the rule in endocrinology in general is you need the inactive form to be plentiful in order to convert it to the active form to do its job. And this is why the vitamin D story is such a complicated one, because the prescription vitamin D version is the active form that we give in cases where they cannot convert to the active form, like in kidney failure,
Yes.
and other situations. And that one, the green, it's a blue-green gelatin capsule. You know, the minute somebody says, "Oh, my doctor gave me a prescription, said I only need to do this for a few weeks and we'll be done." And my question is always, is it blue, green, or white? Because if it's white, it's right. So if it's blue, green, it's wrong.
Mhm. Mhm.
Now, vitamin D, interestingly, I've had quite a few patients over the years who've been very unable to tolerate vitamin D supplementation for a variety of reasons. Usually they have some sort of severe GI disturbance. And so I do recommend tanning 5 minutes a day in just the UVB. They're just 5 minutes. They don't even get tan. No color changes.
Mhm.
Obviously, they do it without sunscreen on. And we do it until their vitamin D levels get up to a decent level, like say above, 50, 55. And then somehow they're able to better tolerate more low dose, consistent vitamin D dosing at that point.
Interesting. I have used the vitamin D lamp in some difficult patients.
Yeah.
Moving on to longevity treatments, kind of tell us what's the hype and what's real with some of the anti-aging medicines, fasting, and I'm very interested in the peptides and what you do for mitochondrial support.
Yeah, the big topic, right? So, what's very real is mTOR inhibition. mTOR inhibition is a mitochondrial function. That's where all the anti-aging work is being done. It's already been shown to be true in multiple animal species other than human. like dogs, cats, mice, etc. So I think that there's actually supposed to be an approval here coming soon for extending the life expectancy of dogs for the same reason. So what inhibits mTOR? Well, that's sirolimus, that's low-dose naltrexone, and that's metformin. I will tell you, I absolutely do not want to use metformin in anybody because of the B12 deficiency issues that you can exacerbate with metformin. And given that everyone is MTHFR deficient, you're dogpiling that. So I don't like the idea of metformin for a lot of people. Obviously, if you're talking about diabetics, we do know that that has decreased cancer risk and decreased cardiovascular risk in diabetics. So sometimes we use it, but not always. Low-dose naltrexone is quite effective on a daily basis for anti-inflammation and people who have aging issues due to inflammation, like chronic inflammatory diseases.
I have a few patients who just swear by it.
Yeah, I mean, I have a few patients who also swear by it. Not a lot. It's a few milligrams. It's not a lot dose.
Right, very tiny.
It also forms the foundation of one of our most successful oral anti-obesity medications, Contrave.
Contrave with
It has naltrexone in it with bupropion, and very effective in those individuals as well. And then, of course, sirolimus is the big one, right? Sirolimus is the big guy. Small doses, weekly doses has been revolutionary for my patients who have unexplained, undifferentiated chronic illness of an inflammatory nature that we can't quite figure out what it is. They've been to rheumatology, they've been everywhere, and they're just inflamed. They're metabolically unhealthy. You can see their lipids, their triglycerides are high, their HDL is low, their blood pressure, they're just metabolically terrible, and we can't figure out why. So we'll do a 12-week trial, and I will tell you, in some cases, it has been miraculous.
I think there's a few people I need to send to Columbus to see you that kind of fit that profile. You know, speaking of mTOR and rapamycin, there's very few situations from my perspective as a menopause expert that I cannot give estrogen or hormone therapy for, right? Because there's very few things that we just reduce all estrogen. So one of them is lymphangioliomyomatosis, LAM. And I've only ever had a couple of cases in my career. And so I saw a woman the other day that was told by her pulmonologist to stop hormone therapy. And I said, okay, well, we'll see if by stopping you got any better or you stopped the progression, because I wasn't really convinced. But she said, well, this is what's recommended. And she brought out the information. And apparently they're using rapamycin for LAM, which I thought was very interesting.
That is interesting.
So I told her,
doesn't surprise me.
Don't be hesitant to take it, and maybe that might potentially open the door for us.
I completely agree. I don't hesitate to use it at all as a trial because it's really low doses. You know, the doses that we use in transplant medicine are hundreds of milligrams daily. We're talking about under 10 milligrams once a week. So fractions of the doses. And, you know, some patients can't tolerate it. I've had a couple of people who couldn't tolerate it, and that's fine, but you don't know till you try. But in those circumstances, for those people who don't tolerate that, who don't tolerate the other therapies, then we go into the mitochondrial support peptides, which are things like NAD, methyl blue.
Do you do those by infusions? Because I know you were saying that oral NADH doesn't really have very good absorption.
Yeah, oral NAD can't be absorbed. It's broken down in the gut. And then you can try taking NMN, but I think the data is still kind of suspect on that in terms of whether you actually get good absorption. So we do it by infusion. We have it by infusion. And then obviously you've got the BPCs for the joint and soft tissue support for people who have acute injuries. And then you've got the growth hormone style peptides like, Sumarelin, tesamorelin, et cetera, ipamorelin, that are like growth hormone, but not. They help, they balance growth hormone. The better way to explain it for the audience, I'm trying to not explain it in a really convoluted way. They're basically the peptides that sort of signal growth hormone. So these are effective in people who have growth hormone, but just want to optimize their growth hormone signaling pathways to get full advantage of their growth hormone. Those don't have much efficacy in people who actually have growth hormone deficiency, because you need an intact growth hormone axis for those to work. So that's why we do such a aggressive job of screening for growth hormone, because if somebody has actual growth hormone deficiency and they want to take some, Sumarelin, tesamorelin, ipamorelin, it isn't going to work. So I'm trying to save them some money and time on that regard, if that's the path that they want to take.
And how do you use methylene blue?
So methylene blue is a methyl donor. So it works like in the MTHFR family, right? So if you have people who have MTHFR abnormalities, let's say they don't tolerate some of the methyl B complexes. I've had a few people who got a lot of anxiety from the methyl B complex vitamins. And so we were using the methylene blue instead to try to give them their methyl donor groups and bypass their need for the large doses of methyl B complex.
That's interesting. The only trouble I've gotten into with really high dose L-methylfolate, of course, I always make sure that the B12 is fine and that they're usually on methylated B12, is because it increases serotonin. And of course, the psychiatrists use
Yes.
it in high doses for depression.
Yes. Yes.
I've had some people tell me that they can't sexually climax. It's like they have too much serotonin on board by pushing it up too much.
Interesting.
Yeah, it's only been a
That's
couple
interesting.
people, and I figured that's the thing. So moving into depression and anxiety and PTSD as we wrap up, and again, we're going to have you back again because you're just so wonderful and delicious. Are you doing ketamine infusions? I know there's like a whole lot out in the space about psychedelics and infusions and other more novel treatments for mood disorders.
Absolutely. Ketamine has, again, I say this and it seems like I may be just hyperbole, but ketamine, like some of the other things that we've been doing, has also been equally ground shaking, revolutionary for the patients who we've been doing it for. So we don't do infusions, we do intramuscular injections. I feel like infusions are entirely too medicinal, medical, anxiety inducing on their own, because you have to have an IV in place. You have to make sure that it's getting a continuous infusion if the patient freaks out or is concerned or isn't getting a good dose. It medicalizes the procedure. It makes it harder for the patient to have a good experience. So we work with our psychiatrists and our therapists in town, and we do an intake review with the patient. We make sure that they're appropriate. We do prefer to do it for people who already are seeking counseling and therapy. So we have a partner in psychotherapy
Sure,
side.
that's so important.
Yeah, because they're coming to us for PTSD, for depression, for anxiety, for trauma, for, recovery. And we don't want to hinder their recovery by only doing the medical part. There needs to be a psychiatric part, a therapy part as a, psychotherapy component. So we do the intramuscular injections. They are medically monitored, and my nurse practitioners in the room with them the whole time. And so they're babysat, so to speak. And we have a protocol where we do it twice a week for 3 weeks for acute therapy. If somebody has an acute event, so like if they're feeling quite depressed, maybe it's an anniversary, that is inducing the PTSD. So especially for veterans, maybe it's an anniversary of, their injury in the field, or an anniversary of a colleague's suicide or something of that nature, or anniversary of somebody who was maybe abducted or abused. Around anniversary times in particular, sometimes people can get a real heightened response, right, of their PTSD. So we'll do it twice a week for like 3 weeks, and then we'll do maintenance therapy after that, whether it's, they transition slowly. Some people go to once a week for a while, then they go to monthly. Other people just go straight to monthly. Some people just do it kind of PRN as needed based on, how they're feeling. Mm-hmm. We do try to combine it with fasting because, as you were mentioning earlier, fasting is the best way to inhibit mTOR and to improve aging, doing a routine fasting. So I try to do at least one, if not two, 72-hour fasts a month. And that usually means
that's good. I can only make it 22 hours and then that migraine comes.
Yeah. Well, so a lot of that's hydration. I will do electrolytes sometimes during it. I try to do it when I'm traveling because it's easier when I'm in a hotel and I'm not, my snack foods are not right here beside me. And so I'll typically, fast like Wednesday, Thursday, Friday, and then go to the gym on Saturday when I return from my travels, and then resume eating on Saturday. So I do try to combine the fasting with the ketamine, and I find that gets really great results mental health wise. Try to get them to fast the day of the ketamine and maybe even the day after the ketamine. And so they at least get a 48-hour fast if they can do it. More on the routine patients rather than the ones who are coming in twice a week. That would be too much fasting to do it for 48.
Well, thank you so much, Dr. Christofides, for joining us on the Speaking of Women's Health podcast. And thanks to our listeners for tuning in. We're so grateful for your support. And we hope that you consider sharing this podcast with others. You can donate to our nonprofit, speakingofwomenshealth.com, and leave us a 5-star rating. And to catch all the latest from us, you can subscribe on Spotify, TuneIn, Apple Podcast, and it's completely free. Thanks again for listening, and we'll see you again next time in the Sunflower House. Remember, be strong, be healthy, and be in charge.